Hello, 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 hello. Today I would like to discuss about the hematology. Okay, starts with this fetal erythropoiesis. Fetal erythropoiesis occurs in from birth to up to adult, and we can remember this mnemonic: young liver speaks, young liver synthesizes blood, young liver synthesizes blood. That means yolk sac, it is 3 to 8 weeks, liver 6 to 6 weeks to birth, spleen 10 to 28 weeks, and the bone marrow is 18 to 18 weeks to adult. This is the mnemonic that young liver synthesizes blood. And the hemoglobin development, fetal hemoglobin is alpha 2 gamma 2. That means hemoglobin F is alpha 2 gamma 2, and adult hemoglobin is alpha 2 and beta 2. And hemoglobin F has higher affinity. Hemoglobin F has higher affinity for oxygen due to less avid binding of less avid binding of 2,3-BPG, less avid binding of 2,3-BPG, allowing hemoglobin F to extract oxygen from the maternal hemoglobin A1 and A2 across the placenta. Hemoglobin A2 alpha 2 gamma 2 is a form of adult hemoglobin. Alpha 2 and delta 2 is a form of hemoglobin, is a form of adult hemoglobin present in small amount. These alpha 2, delta 2 present in a small amount. That means alpha always, gamma goes and becomes beta. Okay, after discussing this thing, I would like to discuss a stem. Like a 7 week old boy comes to you, admitted in the NICU. He was born at 32 weeks of gestation. That means he is preterm baby, preterm liver. After delivery, there is short course of prophylactic antibiotic is given, but no bacterial growth. Other than difficulty of feeding, he has no other issues in the NICU. By week by age weeks of 6 weeks, the patient was taking a normal volume of fortified preterm formula and gaining weight appropriately. There is appropriate weight gaining. He's on formula feeding and he's on ferrous sulfate. Cardiac auscultation there is 2 by 6 flow murmur, systolic flow murmur, but no gallop. Hemoglobin 8, low hemoglobin, platelet normal, reticulocyte count 1.4%. The patient, in spite of getting iron, because as mother's milk, that means breast milk has low vitamin D, as a mother's milk has low vitamin D, and there is chance of having less iron in this age, so patient is on iron. In spite of having iron, there is again low hemoglobin, so there is some problem. And we do PBF, and there is normocytic normochromic blood red cell. So low hemoglobin, their IDA should be microcytic hypochromic. Why there is normocytic normochromic? So there is something wrong, as he is in ICU. In ICU, we know that there is a high level of oxygen is given. So these increased oxygenation causes decreased EPO production. Increased oxygenation causes decreased EPO production and impaired transition from hepatic to renal EPO. This causes exacerbating factor in premature infant like decreased RBC lifespan, frequent blood draws, and iron depletion. This is called anemia of prematurity. So these normocytic normochromic anemia with a minimal reticulocyte count response, normocytic normochromic anemia with a minimal reticulocyte count response, which indicate the bone marrow is not producing adequate red blood cell to compensate for the anemia. This the most likely cause of this 7-week-old preterm infant is anemia of prematurity. At birth, increased oxygenation, breathing, ductus closure triggers. Increased oxygenation triggers reduced erythropoietin production by the liver and the kidney. Low levels of EPO impair erythropoiesis in the bone marrow, which normally cause a mild transient anemia that reaches the nadir 9 to 11 that reaches nadir 9 to 11 gram per dl at 2 to 3 months in term infant, and at age 2 to 3 months in term infant. Physiological anemia of infancy compared to term infant, preterm infants have low initial hematocrit at birth, a shorter erythrocyte lifespan, and less capacity to produce renal EPO. Therefore, their erythrocyte nadir tends to be more severe, 7 gram per dl, and occur earlier, 1 to 2 months, resulting in anemia of prematurity. Frequent phlebotomy in the neonatal ICU can further exacerbate this symptom. Many cases of anemia of prematurity are asymptomatic. However, mild tachycardia is common, and a flow murmur, apnea, poor weight gain can occur. Lab evaluations show normocytic normochromic anemia with a normal platelet, or normocytic normochromic anemia, normal platelet and leukocyte. Absolute, although absolute reticulocyte count may be normal, for age, and reticulocytosis in response to the anemia is absent, as seen in this patient. Reticulocytosis in response to anemia is absent in this patient. Okay, this is ABO classification, this is RH classification. We know that O negative is universal donor and AB positive is universal recipient. Difference between hemolytic difference between RH hemolytic disease and ABO hemolytic disease. Hemolytic disease of the newborn, also called erythroblastosis fetalis, most commonly involves the antigen most commonly involves the antigen of the major blood group Rh and ABO, but the minor blood group incompatibilities can result in this disease. Rh hemolytic disease and AB hemolytic disease. Rh hemolytic disease, Rh negative pregnant patient and Rh positive fetus. Rh negative pregnant patient and Rh positive fetus. And abiohemolytic disease type O pregnant patient, type O pregnant patient, and type A or B fetus. Mechanism: first pregnancy, patient exposed to fetal blood often during delivery, formation of maternal anti-IgG. Subsequent pregnancy, anti-IgG cross the placenta, attacks the fetal and newborn RBCs and thus causing hemolysis. Their presentation is hydrocephalus, jaundice shortly after birth, and kernicterus. Hydrocephalus, jaundice shortly after birth, and kernicterus. Prevention: it is prevented by administration of anti-DIgG to RH, anti-DIgG to RH negative pregnant patient during third trimester and early postpartum period. And prevents maternal anti-DIgG production production. Abiohemolytic there is pre-existing pregnant patient anti-A or anti-B IgG antibody can cross the placenta and attack fetal and newborn RBC and thus causing hemolysis. Mild jaundice in the neonate within the first 24 hours of birth. Disease, Unlike Rh, hemolytic disease can occur in first-born babies. Usually less severe. Treatment is phototherapy or exchange transfusion. Treatment is phototherapy and exchange transfusion. Okay, so what happens in the anemia of prematurity? There is increased oxygenation, less hypoproduction, and there is decreased exacerbating factor is decreased RBC lifespan, frequent blood loss, and iron depletion. There is normocytic normochromic anemia, but inadequate reticulocyte response. This is high yield. Inadequate reticulocyte response. Though there is low hemoglobin, but your reticulocyte count is not increased. What you can do: RBC transfusion is severe or symptomatic, minimize exacerbating factor, iron supplement, limit blood draws. The next question: when you see a blood flame looks like hairy cell, diagnosis is done. Hairy cell leukemia. This is a clonal B cell neoplasm. Usually milder age and older adult, and there is BRAF mutation. In hairy cell leukemia, we know that all cell line goes down, except the leukocyte anemia, thrombocytopenia. Sometimes there is leukopenia or granulocytopenia too. There may be splenomegaly, which can be seen in the form of early satiety. Splenomegaly features would be early satiety. So, how will you diagnose the recent? Suppose a patient with two recent episodes of pneumonia having splenomegaly, anemia, thrombocytopenia, mild leukocytosis, and peripheral blood smear show a leukocyte with a hairy cytoplasm. Diagnosis done. Hairy cell leukemia. Hairy cell leukemia. In here, diagnosis require flow cytometry. Bone marrow flow cytometry diagnosis require. So a patient with anemia twice a year, anemia twice a year, there is mucosal pallor, there is splenomegaly, and PBF shows this hairy cell pattern, hairy leukocyte cell, and it is confirmed by bone marrow biopsy. It is confirmed by bone marrow biopsy. In acute lymphoblastic leukemia, you will get lymphoblast, and in CLL you will get smudge cell. In CLL you will get smudge cell. In Hodgkin lymphoma you will get some Ritzenberg cell. Suppose a patient leukocyte is more than 42,000. There is fluorescence in situ hybridization reveals an abnormality in the chromosome of chromosome number 22. In chromosome 22, that means important target in treating the patient disease. So it may be CML, and that we know that the drug of the CML is BCR-ABL tyrosine kinase. That means imatinib, nilotinib, dasatinib, or all mitinibs. CML. There is clonal myeloproliferative disorder. Uh, driven by the abnormal fusion gene of the BCR-ABL. These genes causes leukemogenesis due to a constitutively and active tyrosine kinase. First line treatment for most CML patient is tyrosine kinase inhibitor imatinib. Although these drugs are not curative, they often can induce long term remission. They can cause long term remission. Patients with CML asymptomatically, although fatigue, night sweat, and patient may experience weight loss and early satiety. Peripheral blood film in the CML reveals a dramatic leukocytosis with absolute basophilia, and the shift toward very early neutrophil precursor fill. Suppose a 17-year-old boy with chronic ITP comes to you for follow-up. Initially diagnosed ITP over a year, and there is prolonged epistaxis. Develop prolonged epistaxis after colliding with another player during soccer game. He has received treatment with multiple medication, including IVIG and prednisolone. His response to treatment has been transient and decreased rapidly. Physical examination show diffuse petechiae and a few areas of ecchymosis. Hemoglobin 13 platelet count is 10,000. ABO workup of the autoimmune disorder, chronic viral infection, bone marrow, normal cellular, slightly increased megakaryocyte, which of the best step? Coombs negative, ABO, O negative blood group, there is no autoimmune, viral is negative, bone marrow evaluation reveals a normal cellular marrow with slightly normal cellular marrow with slightly increased megakaryocyte, Which of the following is the best next step? Which of the following is the best next step in the management? That is splenectomy. That is splenectomy. Patients with ITP. ITP resolves within 3 months. However, some patients contain platelet less than 1 lakh for a year, which may be said as chronic ITP. Chronic ITP, bone marrow examination, blood test for infection, you will give glucocorticoid IV. The patient has bleeding and thrombocytopenia requiring repeated pharmacological intervention should be considered for second line. Rituximab, thrombopoietin receptor inhibitor, and splenectomy, although not without risk. Splenectomy remove the source of the platelet destruction is often curative in patient with ITP. It is a curative treatment in a patient with ITP to remove the spleen. Removing spleen is the uh, curable treatment for ITP. And in ITP, there is platelet autoantibodies and there is preceding viral infection. Okay, in neutrophil, there is acute inflammatory response. The acute inflammatory response cell phagocytic multilobe nucleus, phagocytic multiple nucleus, and specific granule. In neutrophil, there is specific granule called leukocyte alkaline phosphatase, LAP, collagenase, lysozyme, and lactoferrin. Leukocytes, leukocyte, alkaline phosphatase, collagenase, and lysozyme. Azerophilic granules, lysozyme contain proteinase and myeloperoxidase and beta-glucuronidase. And inflammatory states for bacterial infection causes neutrophilia, and change in neutrophil morphology should mm, dull bodies, light blue cytoplasm peripheral inclusion, dull bodies, light blue peripheral inclusions, and cytoplasmic vacuoles, and cytoplasmic vacuoles in seen In neutrophil. In neutrophil, chemotactic agents C5a, LTB4, IL-8, and bacterial product and 5-HT, leukotriene precursor, kallikrein, platelet activating factor, and N-formyl methionine, bacterial protein, N-formyl methionine, bacterial protein. There is hypersegmented neutrophil more than nucleus at 5 or 6 plus lobes are seen in vitamin B12 and folate deficiency in vitamin B12 and folate deficiency. Increase a left shift, increase neutrophil precursor in the peripheral blood reflex increase myeloid proliferation reflex in states of increased myeloid proliferation, inflammation, and CML. Leukoerythroblastic reaction left shift accompanied by immature RBC suggests bone marrow infiltration, myelofibrosis, or metastasis, increased neutrophil precursor pan-cell metamyelocyte in the peripheral blood reflexes in the myeloid proliferation, inflammation, and CML. Leukoerythroblastic reaction left shift accompanied by immature RBC suggests bone marrow infiltration. Left shift accompanied by immature RBCs. In erythrocytosis, polycythemia, high hematocrit, anisocytosis is variation in size, poikilocytosis is variation in shape. Bluish color polychromasia or bluish color or polychromasia or white Giemsa stain of the reticulocyte presence. Reticulocyte represents residual ribosomal RNA. Residual ribosomal RNA membrane content chloride bicarbonate antibody which allows RBC to export bicarbonate and transport carbon dioxide from the periphery to the lung for elimination. Peripheral to the lung for elimination. Thrombocytes contain calcium, ADP, serotonin, histamine, calcium, ADP, serotonin, and histamine, and alpha granules of von factor, fibrinogen, fibrinonectin, and platelet factor 4. These are the things contained by the thrombocyte or platelet. That means dense manure contains some cash like calcium, ADP, serotonin, histamine, and alpha granule contains some fibrinogen with von factor, fibrinogen, fibrinonectin, and platelet factor 4. Thrombocytopenia or decreased platelet function results in petechiae. Thrombocytopenia and decreased platelet function results in petechiae, von factor glycoprotein 1b, von factor glycoprotein 1b, and fibrinogen receptor glycoprotein 2b or 3a. Thrombopoietin stimulate megakaryocyte proliferation. Alpha granule contain von factor and fibrinogen, fibrinonectin, and platelet factor 4. Monocytes found in the blood differentiate into the macrophage or dendritic cells in tissue. Large kidney-shaped nucleus, extensive frosted glass cytoplasm. Again, with another stem, a 13-month-old girl brought to the office by her mother due to concern about bruising. Concern about what? Bruising. The mother first noticed that bruising around the daughter's eyes bruising around her daughter's eyes 2 weeks ago after the patient returned from a weekend at her father's house. She recently started walking and falls frequently. The bruising was attributed to bumping her head on a coffee table. The bruising has since the persistence. Mm, mm, The abdomen is distended. There is 6 centimeter palpable firm mass in the anterior to the left flank. There is mass, there is weight loss, there is rapid sharking movement of the eyes, infraorbital ecchymosis, there is bruising, lots of things. So my diagnosis should be neuroblastoma. The neuroblastoma is a neural crest tumor. Also involves adrenal medulla and sympathetic chain. Median age is less than 2, abdominal mass, periorbital ecchymosis, and spinal cord tumor from epidural invasion, dumbbell tumor. There is opsocronus myoclonus syndrome. Diagnostic finding: elevated catecholaminé metabolites, small, round, blue hue on histology. There may be anemic amplification. So neuroblastoma, neural crest, anemic amplification, neuroblastoma is a numbel, that means dumbbell tumor, spinal cord compression from epidural. In neuroblastoma, there is blast, obscureness, myoclonus syndrome. There is ecchymosis. There may be abdominal mass. There may be median age less than 2. Elevated catecholaminé and metabolite, small round, blue on-site histology. There may be N-MIG. There is periorbital ecchymosis, raccoon's eye, which are caused by orbital metastases that obstruct the blood vessel. Obsoclonus or rapid eye movement is rare, and it is called obsoclonus and myoclonus syndrome. Okay, I'm back. After having breakfast, I'm back with another show.